Now I'm going to welcome our presenter. Dr. Mark Heyman is the director of the Center for Diabetes and Mental Health, a medical group practice located in Solana Beach, California. He concentrates on providing specialized mental health services to people with diabetes. He develops and delivers training and educational materials to healthcare providers on psychosocial issues related to diabetes. Dr. Heyman received his PhD in clinical psychology from the George Washington University in Washington, D.C. Welcome, Dr. Heyman. The floor is yours.
Thank you so much, Mary. I really appreciate it, and thank you all for joining me today. As Mary mentioned, my name is Dr. Mark Heyman, and I'm a psychologist, and I specialize in diabetes. And as I'm sure that folks on the phone right now, this audience really understand, living with diabetes is really hard. People who live with diabetes, they do the majority. They have to manage their diabetes on their own for the most part. They see their doctor maybe once every 3 months, but the majority of their diabetes management is done on a daily basis on their own. And that management can be really challenging and really overwhelming. And so the psychosocial needs of folks with diabetes is really important and really what I focus on today. And today I want to talk about diabetes burnout and what that is and what are some things that we can do about it. This presentation is relevant for all types of diabetes, both type 1 and type 2. While the issues may be slightly different, I think that the issues of self-management and the psychosocial and emotional aspects of diabetes, which really impact behaviors, are very much the same. Now, when I think about diabetes and mental health, I think about them very, very broadly. While there are certainly folks who live with diabetes who also have a diagnosable mental health condition, there are many others who are just having a hard time. Maybe they don't qualify for a mental health condition. They don't have major depressive disorder. They don't have an anxiety disorder, but they're dealing with some emotional issues related to diabetes that are really important to understand, to evaluate, to assess, and to understand, and if possible, to address them. And this is really important because not only do these psychosocial issues impact patients' quality of life, which is an important aspect, for folks who are dealing with people with diabetes, they also deal with behavior and their diabetes management behavior, which really has a big impact on glycemic control. So paying attention to these issues, particularly diabetes burnout, I think is a really critical thing. So today's presentation is going to have 4 parts. The first thing I'm going to do is I'm going to introduce you to some patients who are experiencing diabetes burnout. And I'd like you to keep these patients in mind as we go through this presentation so that you can kind of see how they fit into what diabetes burnout is. And at the end, we'll come back to these patients and we'll talk about, what came of them. What were the interventions that we used to help them? Were they helpful? Then we're going to talk about what is diabetes burnout. We're going to really try to define it. It can be sometimes an amorphous term. And so we want to define it to the best that we can. We want to give you some tools that you can use to assess diabetes burnout. And then finally, we want to talk about some things that we can do to address diabetes burnout in your patient. And now I wish I could tell you that I have a magic bullet where we can, after you hear this presentation, all you have to do is go and talk to your patients and say these magic words and their burnout will go away. Unfortunately, that's not the case. But what I can do is I can give you some tools that you can use and some things that you can address with your patients that can help them to overcome their diabetes burnout and to really live well with diabetes. So without further ado, let's look at some phases of diabetes burnout. Diabetes burnout has many phases, and I want to introduce you to some patients that I've seen. There are some details that have been changed to protect confidentiality. But I think that it's helpful to look at the different types of patients that we see with diabetes and what their burnout might look like. So first, let's talk about Frank. Frank is a Caucasian male. He's in his mid-50s, and he's had type 1 diabetes for a long time. He was diagnosed when he was 7 years old, so he's been living with diabetes for 47 years. He talks about the dark ages of diabetes, when blood glucose management wasn't easy, blood glucose measurement was not easy, and things were going on in his life where the technology just wasn't there. But overall, throughout his childhood and adult life, Frank was able to manage his diabetes pretty well. recently, over the past 5 years or so, Frank has been experiencing some life stressors that have really made him feel out of control with his life, but consequently with his diabetes. Frank's gone through a divorce, and also he's developed several diabetes complications. And so, as a consequence of that, he's really felt helpless and really felt hopeless and really felt like nothing that he could do is really going to matter. And so, when I started seeing Frank, he was only checking his blood glucose once every couple days, and he was dosing insulin without checking his blood glucose. He had some very severe hypoglycemic episodes, and it was very problematic for him. Next, we talk about Cindy. Cindy is a middle-aged nurse who is retired, and she was diagnosed with type 2 diabetes just a couple of years ago. And she commented to me more than once that if she knew how hard living with diabetes was when she was working with patients with diabetes in the hospital, it would have given her a whole new perspective on their challenges. Now, Cindy's big issue is that she feels overwhelmed with what she has to do. Like whatever she does to manage her diabetes is not going to be good enough. She knows that she needs to make changes to her diet. She knows she needs to exercise more. But she has the sense that whatever she does, it's not going to be enough, and that she can never meet the goals that she needs to meet. And this has really made her feel very, very angry, and really feel that diabetes has a lot of control over her life. Even though she can't actually meet the expectations that she set for herself, she feels that because she can't meet them, it controls her every move and everything that she does in her life, and that's really, really challenging for her. And last, I'd like to introduce you to Blake. Blake was a really tough patient. He's a college student. He's had type 1 diabetes for 14 years. And one of the biggest challenges with Blake was that he feels very alone. He had never met someone with diabetes or another person who had diabetes. And this has made him feel very alone and isolated and feel like the struggles that he's had are his alone, and that he is different from everybody else, including people with diabetes. Blake recently moved home from college. He basically had to leave college because he'd been hospitalized with DKA. He doesn't manage his diabetes at all. He checks his blood glucose very infrequently, and he takes mealtime insulin only sporadically. He does take basal insulin, which is interesting, on a regular basis. I think that having being hospitalized with DKA scared him enough to take his basal insulin on a regular basis, but prandial insulin only sporadically. And like most patients with diabetes burnout, he knows the risks of not managing his diabetes, but he can't really conceptualize what that actually means, what the consequences are. And he's made the decision that, living his life now as a college student, as a young man, going out and dating and going to parties is really more important than managing his diabetes well. And managing his diabetes is not worth the concept or the inconvenience of giving up things, or his perception that he has to give up things that are important to him. So now I'd like to talk about, using these patients as in context, I'd like to talk a little bit about what is diabetes burnout and what it's not. As you can see from the patients that we had looked at, diabetes burnout has a couple of components to it. It really has an emotional component to it. It really has a behavioral component to it. The emotions really can drive the behavior or non-behavior. And it also has a cognitive component to it. Thoughts about diabetes and what that means about, oneself or about the world can really, really have an impact on patients. So I'd like to share with you this quote. It comes from a woman named Joan Williams Hoover, who was it's thought that she is the one who coined the term diabetes burnout in a paper that she wrote in the early 80s. And it says, think about how discouraging it is to fail at something you really wanted to do. And then consider what it must feel like to have diabetes and be failing at something that you never, ever wanted to do in the first place. I think that one thing that's important to remember is that, that people are motivated to do things that are going to be helpful to them and that they want to do. And no one wants to get diabetes, or I certainly have never met anybody who does. And so, helping someone to get motivated to do something that they don't want to do, or to constantly fail at something that they don't want to do, can be really challenging. I think this quote from Joan Williams Hoover can be really helpful in thinking about these patients and really, helping to increase empathy for them, which is a critical part of helping them to manage diabetes burnout. So according to this definition, there's no real standard definition for diabetes burnout, unfortunately. It's a term that we use a lot in the literature, but there are various definitions for it. But this one I really like. It's from the Joslin Diabetes Institute website. And it's a state in which patients with diabetes grow tired of managing their disease and then simply ignore it for a period of time, or worse, forever. This is, I think there are a couple important things to note in this definition. First is that it can happen for a short period of time, or it can happen forever, or it can happen sporadically. So folks, they may be motivated 1 week, and then the next week they may feel burnt out, which is a very normal part of the process. I think that diabetes burnout, I think it's important to frame this in saying is that it's a very normal thing, and that most people with diabetes at some point in their diabetes life feel burnt out. But I think that the big differentiator is a matter of how they deal with it and how they manage it, and what skills and tools and abilities they have to overcome the burnout when it does present itself. So let's take a look right now about what diabetes looks like, what it looks like from this perspective. I mean, you can think about it in terms of your patients. You can think about it in terms of the patients that I presented to you a minute ago. But there are several components of diabetes burnout that I think that are important to point out. First is that people who have diabetes burnout have strong negative feelings about diabetes. They could feel overwhelmed. They could feel angry. They could feel frustrated. They can feel hopeless and helpless. They can certainly feel depressed. And they feel controlled by diabetes. One thing I like to think about, in terms of diabetes burnout, is that if anybody is experiencing these feelings, anybody at all, whether they had diabetes or not, the immediate reaction that we have naturally as human beings is to do our best to avoid them, is to push them away, and to do our best not think about them, not talk about them, not deal with them. It's a very natural human reaction. It's not always the most adaptive. It's actually very rarely adaptive, the most adaptive response. But it's a natural thing to do. And so when doing this with diabetes, the big problem is not only are we pushing the emotions away and not dealing with them, but by doing that, oftentimes that pushes the behavior away too, and that's the behavior of glycemic management. People with diabetes burnout oftentimes feel isolated or very alone with diabetes. Just like Blake, who talked about it a minute ago, people with diabetes oftentimes have never met others with diabetes. That's particularly true in the type 2 population, but many people with type 1 diabetes as well feel very alone. They're not plugged into the network of folks with type 1 diabetes that do exist, and there are some great communities out there that do exist. However, but many people they feel isolated and alone, and like what they're experiencing, no one else has experienced, no one else does experience, and that can really make people want to avoid it, because if no one else is dealing with it, why should I have to do that? And then there's a behavioral component to it. This really involves avoiding diabetes management, or it can involve that, not always, but certainly some diabetes management. So eating foods that are not glycemically friendly, not taking care of yourself, whether that's diet and exercise, or whether that's not testing blood glucose levels, whether that's not taking insulin or other medications as prescribed. And then there's also a piece of being unmotivated or unwilling to make efforts to change this behavior. And this is kind of where the real big challenge comes, is that we know what can help glycemic control, what can help good glycemic control. But when a patient is unmotivated to do so, even though we know the consequences, or unwilling to do so, that's where we really get stuck, and oftentimes we get, people start digging their heels into the sand and aren't really able to make progress forward. And so I really I'm hoping to be able to give you some tools today that you can use to help patients to kind of break that unmotivated rut that they're in, and to be able to make some of these changes. I think it's also really important here to talk about what diabetes is not. One thing is it's not uncommon. That's not on this list, but diabetes burnout is not uncommon at all. People with diabetes experience it all the time, and they experience it in very different ways, so it may look different from one patient to the next. But diabetes burnout is not laziness. People with diabetes aren't lazy. I hope any of them aren't, but certainly just because you have diabetes burnout does not mean that you are lazy. There's a lot more to it than that. So there's an emotional factor, and there's a belief system, and there's thoughts that really kind of drive that. And so don't have the assumption that if you're dealing with a patient who has diabetes burnout that they are lazy, or please don't label them as being lazy. The next thing is depression. There's a lot of debate in the literature right now, and there's about depression and diabetes. For a long time, we thought that a significant number of people with diabetes experience depression. And recently, there's been some research, which we'll talk about in just a minute with some of the assessment measures, looking at is it depression, or is it something more specific to diabetes? Depression, for the most part, generally speaking, is broad, and it really encompasses all aspects of life for folks. And people with diabetes burnout, they certainly may be experiencing depression, but their issue may also be specific to their diabetes. And so please, I think it's important to remember that people who have diabetes, burnout, or people who are experiencing diabetes burnout, do not automatically have depression. And that's an important both from a way we think about our patients, but also the interventions that we use. Because if we use an intervention for depression on someone who has diabetes burnout, that can be problematic because it may not be the most effective treatment. And then the last thing I want to point out is that people with diabetes burnout don't have a lack of concern about their health. Oftentimes, they very much know the consequences of their behavior, but they have that unmotivated. They're not as motivated as they want to be, and they really want to be more motivated. And they really just don't have the tools necessary to be able to become more motivated. Also, oftentimes they have the belief that even if they did have the tools, they're not going to be successful. They're not going to be successful in that process. And so I think that it's important in this process, to really partner with patients to help them, to give them the tools and give them the hope that they need to be able to be effective in overcoming their burnout. So the key takeaways here is that living with diabetes is really hard work. I don't think that there's any disagreement with that there. But it's more than just work. It's more than just following the rules and eating right and taking medication, insulin or otherwise, exercising, things like that. There's really those are certainly very important, but there is a cognitive component and there's an emotional component which really drives that behavioral component. And I think that it's really important to keep that in mind when working with patients who are struggling with burnout. Next, diabetes burnout is really common. This is not an issue that happens to only a couple patients out of 100. I think that there's not great data out there, but I would venture to say that most patients who live with diabetes at some point in their diabetes life have experienced burnout, and there may be more patients that you're dealing with, that you're working with right now, than who are experiencing burnout. We really want to be able to find ways to assess them and to understand them and to really help them. But I think the last takeaway here that I want to really emphasize and expound upon throughout the rest of this presentation is there is hope. There are things that we can do as both healthcare providers, but also the patients can do to help them to overcome their burnout. There have been many people who have been successful, and it's an ongoing process. It's not a process of someone gets treatment and then all of a sudden they never have burnout again. But it's a matter of giving patients the tools that they need to be able to manage their diabetes effectively, and when burnout comes along, to be able to address it and help them to reverse course with it. Now,
Okay, thank you, Dr. Heyman. We're going to come to our first polling question, and I'm going to read it out loud and then push the poll and let the attendees answer it. According to a study published in 2015, what percentage of patients with type 1 diabetes reported at least moderate levels of diabetes distress? A, 11.3%, B, 24.7%, C, 32.8%, and D, 41.6%. So I'm pushing the polls, and we'll give everybody a minute or so to answer. And while we're doing that, I'd like to ask you to share with our attendees how you got involved in diabetes and diabetes burnout in particular as your life's passion.
Sure, I'd be happy to. One thing I didn't mention at the beginning of this presentation is that I live with diabetes. I was diagnosed with type 1 diabetes when I was in college, and when I was first diagnosed, I was very. I should also say that I'm very lucky that I had never really experienced significant psychosocial or emotional issues related to living with diabetes. That's not to say that I never will, but I haven't to this point. But I was really interested in finding out what resources are available for folks who are living with diabetes, not only from a medical point of view, but also from a psychosocial point of view, which is something that's been always very, very interesting to me. And so I started doing some research, and I realized I was shocked, a little bit shocked, that there weren't many resources for patients, and there was not a lot of information or knowledge about these issues back in the late 90s. And so, long story short, I decided that I wanted to focus my efforts on diabetes. I started off with just type 1 diabetes, but my interests have really broadened to type 2 diabetes as well, because I think that population is critical because it's growing very fast. But they have some unique challenges that I think can be addressed with more research and more support. And I'm really passionate about what I do from both from a personal perspective, but also from a professional perspective.
Thank you for sharing that. That's really helpful for all of us. I'm going to go ahead and close the attendee poll now, and then I'm going to go and push the results so that you can address them. The floor is yours.
Sure, thank you. So you guys, so it looks like 59.6% of the respondents said 41.6%, which is the correct answer. This was done in a study with people with type 1 diabetes, and a significant number. And this is a study that was done at one time point. So a significant number of folks with type 1 diabetes at this time, out of 305 participants in the United States, reported at least moderate diabetes-related distress. So I think that's an important thing to keep in mind with your patients, is that almost half of patients, at least in this study, but I would say that this generalizes fairly well, have at least moderate distress, and that really has a big impact on their quality of life, and it also really has a big impact on their glycemic control. It's interesting to note that in this study at least, higher diabetes-related distress was reported in women, people with complications, people with low glycemic control, people without a partner, and people who are of younger age. So those can be considered risk factors for diabetes-related distress, at least in this population. All right. So now that we know a little bit about what diabetes distress looks like and what it is, you may be asking yourself, how do I know if my patient has it? And I want to give you some tools and some resources that you might think about using, both by themselves or in combination with one another, to help you get a better idea about if your patient is experiencing diabetes-related distress or diabetes burnout. And there are a couple different assessment tools that are out there that you can use to help you to assess your patient. And I'm going to introduce a couple of them to you right now. and I can explain how you might use them as a tool for yourself in your practice. But I also want to talk to you about your clinical skills, because I think that can be one of the most effective tools you can have, is not only using a tool that someone else has developed, but also using yourself as a person, using your empathy, using your curiosity to help your patient. Now, before I go on, I want to note that I'm going to introduce to you two tools, the Diabetes Distress Scale and the Problem Areas of Diabetes Scale. And I want to mention that these are self-report assessment tools. So they're tools that you can give to your patients, they can fill out. And like any tool, this has some advantages and it has some disadvantages. The advantages of these tools are that if you use them, they can give you an opportunity to capture quantitative data. And that's really powerful because it can really help us to see changes in patients. So if you give a patient an assessment tool at a certain time point, and then you give it to them 3 or 6 months later, you can really see if anything has changed, and what in some of these tools, what specifically has changed and what hasn't changed, and that can really help you in intervention and helping your patient. These tools can also give us some guidance as to what types of questions are important to ask. These tools have been validated, and so even if you may not use the tool in its entirety, it can give you some guidance as to what types of questions might be helpful for you to ask when communicating with your patients on a regular basis. On the other hand, there are some disadvantages to using these assessment tools, especially assessment tools just giving patients a paper and pencil assessment, having them fill it out each time you see them. And the first one I think we should mention is that they're self-report tools. And so patients are not very good oftentimes at self-reporting their data, especially when it comes to emotional and behavioral data. Either they get scared of telling the truth, or they can't recall, or sometimes they can't tell the difference between categories, whether it's very, very frequently or just frequently. They have trouble distinguishing between those. And so self-report data is not always the most effective way of collecting data. These tools can also be a little bit repetitive, and they can be awkward and time-consuming to give. Giving your patients an assessment every time you're seeing them, especially if you're seeing them very regularly, can be a little bit awkward, and oftentimes patients can just go through them and circle the answer that is easiest, whatnot. So I'm going to present these tools, but I also want to present, as people who are working with people with diabetes on a regular basis, it's important to think critically about what the most effective tool to be using with these patients is. So the first tool I want to present is called the Diabetes Distress Scale, and there's actually two versions of this. The DDS2 is a screening scale. So it's a very simple 2-question scale that respondents take, and in doing so, they rate the degree to which they are feeling overwhelmed by the demands of living with diabetes, and feeling that they're failing their diabetes regimen. And then there's a longer version of the scale, which is a 17-item scale. And the great thing about this scale is that it has different domains. So you can tell where patients are experiencing the most distress, if there's a difference in their experience. So it has a scale for the emotional burden of diabetes, physician-related distress, regimen-related distress, interpersonal distress, all of which are very important, but they have found to be distinct categories in diabetes-related distress. And so here is a screenshot of the diabetes distress scale. There's just 2 questions, and it's rated on a scale between 1 being not a problem and 6 being a very serious problem. And then here's a screenshot of the diabetes-related distress scale. And I know it can be hard to read, so I can read a couple of the questions for you. Feeling the diabetes is taking too much of my mental and physical energy every day. Feeling that my doctor doesn't give me clear enough directions on how to manage my diabetes. Feeling that I'm failing with my diabetes-related routine. Feeling that diabetes controls my life. So there are a lot of questions in here that can be really helpful for you in terms of doing assessment with patients, either as a whole or using it as a guide to have a conversation with patients and getting some ideas about the types of questions and the types of categories that you might use in talking to your patient. Of course, the great thing about using the scale as a whole is that at the end you can score it, and you can look at the norms and see where your patient falls on a scale. But in the end, if a patient is experiencing distress, whether or not they break any kind of they go over any of the clinical norms. That's good information that you could have that can really help you to intervene with them. The other scale that's popularly used is called the Problem Areas of Diabetes Scale. And this is a 20-item scale that describes common problematic situations for people with type 1 and type 2 diabetes. And it's a helpful scale. I should say a couple of things. One is that the Problem Areas of Diabetes Scale does not have those subcategories. And so it can be a great guide to questions. It can also be a great assessment tool. But if you're looking to get more detailed as to, is a patient experiencing physician-related distress or emotion-related distress, this one does not have those subcategories. And as you can see, here's a small screenshot. There are questions like, and these are rated on a scale from not a problem being 0 and 4 being a serious problem, to not having clear and concrete goals for diabetes care, feeling scared when you think about living with diabetes, feeling depressed when you think about living with diabetes, feeling overwhelmed when you're thinking about living with diabetes. So that kind of gives you some good categories to use either in a conversation or as a whole. I should also mention that there's also that in the diabetes distress scale there is a scale that's been developed specifically for type 1 diabetes as well, which I didn't share here, but it is available if you're working with patients with type 1 diabetes and you want to give them a scale. That being said, I think that really the greatest tool that we have in doing assessment with patients with diabetes is having open communication with them. And I know this can be really, really challenging given the time that we have to spend with patients and the other pressures that we have. But one thing that patients tell me all the time is how much they want physicians and CDEs and other people they're dealing with on the diabetes care team to really listen to them and to really pay attention to what they're experiencing. Because one thing that I hear a lot is that these providers don't really understand. They look at diabetes as really kind of a rules game. You follow the rules and you'll succeed. If you don't follow the rules, you're not. And the reason you're not succeeding is because you're not following the rules. And I think that, as I said before, there's a missing component there, is really that open communication. And so I think that one of the greatest tools that we have to be able to use to assess for diabetes burnout are questions, and are ourselves asking questions and really being curious with our patients about what they're experiencing. And so I've laid out a couple questions here that you can use as guidance for this, but really it's a matter of using yourself as the tool and asking the questions that are important to you and important for you to be able to understand your patient's experience, and important for your patients to feel heard. So one thing that I start off with patients is by saying, living with diabetes is really hard sometimes. What's the hardest part about it for you? And sometimes the floodgates open because no one's ever asked them that question before. And so just really being curious about what's their experience. Because I know my experience personally, and I know patients' experiences, because I deal with a lot of patients. But a big question is, what's your experience? Because each experience is different. Really trying to understand what's been the most challenging part of managing diabetes recently for the patient. What words would they use to describe diabetes? And what about diabetes takes up the most energy for them? And I think that asking questions like these can really give you a great insight into your patient's experience and really help them to feel heard, but also help you to get really good information that you can use to better help the patients who are experiencing distress. As I mentioned before, you can also use the tools that I had just mentioned, the PAID and the DDS, to help guide you in other questions. If you have specific questions around blood glucose management, about blood glucose monitoring, insulin administration, things of that nature, these tools can be really good things you can use to help guide that conversation and to help you to ask the right questions and get the good information that can be really helpful in helping patients to overcome the burnout that they're experiencing. So the key takeaway that I want to emphasize here is that sometimes the best way to assess for burnout is to have a conversation with their patient, to be there for them, to give them the time and the ear and the interest, and ask them about their experience, and really listen to their response, and never assume anything. Each patient, while experiences can be very similar, each patient's individual experience and the stressors that they're living with can be different. And so by really listening and really trying to understand your patient that you're sitting with right there and their experience can be a really powerful tool that you can use in helping them overcome burnout. Mary?
Okay, thank you, Dr. Heyman. Our next question. In the Dawn 2 study, what percentage of healthcare providers said that they would like more training in communication and motivation strategies to support long-term behavior change? A, 8%, B, 39%, C, 56%, or D, 83%. I'm going to push the poll and give our attendees a little bit of time to answer that. And in the meantime, we did have a question from one of our attendees who loved your scales and wanted more information on how they could obtain copies to use for their own patients.
The best answer is Google. I believe that they're both in the public domain. I'd be happy to share with you the references after this presentation, which you can then use to find the places where they were, where they're available online. Or I'm sorry, and also the studies that were used to validate them, because they're actually included in the validation. But I will be happy to provide that information to you to the best of my ability after the presentation, I believe, in the question and answer that I'm going to be writing up.
Perfect. We'll include those in the post-webinar blog. So it looks like we've had a fair number of our attendees answer this question, so I'm going to go ahead and close the poll and push the results and let you please address them.
Thank you. So the correct answer here is actually 56%. Which I think is interesting. I want to take a step back here and talk, if you're not familiar with the Dawn 2 study. The Dawn 2 study was a worldwide study done through many countries. I don't remember the exact number, addressing the psychosocial issues related to diabetes, and really trying to get an idea from the perspective of people with diabetes, from the healthcare providers, as well as from their family and support system, what sorts of issues they're experiencing, and what sorts of resources they have, and what are their needs moving forward. And so this study, or the statistic, was taken from a paper that was written from the healthcare provider perspective. And in it, and this was cross-national, across countries, but 56% of healthcare providers said they needed more resources and more training in this area. I'm not sure, it's unclear whether that means that the other ones either don't think they needed it or have already gotten it. But I think that it's an interesting number in the sense that I think that we can all, myself included, can always use more training resources on how to help patients who are dealing with these emotional issues related to diabetes. And I'm just a big proponent of that. Anything we can do to increase that number, both in helping people understand that these are important issues and that we have training and resources available to them, it can be helpful and it is necessary for all of us, including those of us who are trained in behavioral health treatment. So I want to spend the last part of this presentation talking a little bit about, we know what diabetes burnout is now. We know we have some tools that we can use to assess it. So what do we do about it? If we find that a patient is experiencing diabetes burnout, what do we do? What are some resources and tools that we can use? And I want to focus my talk here on three major areas. The first is on behaviors. The second is on expectations. And what I mean by that is expectations about what diabetes management should look like. And the third is on relationships. And I think that these are some areas that you as healthcare providers have the tools to use to address with your patients without a whole lot of extra training, which I think is really effective. I think if you keep these three things in mind, they can be really helpful for you as you move forward with your patients. So as we talked about before, people with diabetes generally know what they should be doing to manage their diabetes, but they struggle anyway. Diabetes burnout is not a matter of health literacy. It's not a matter of people not understanding what diabetes is and what the consequences are. If you ask most people what the potential complications are, or the consequences of poor glycemic control, most people know that. And they know it from a theoretical level. They may not be experiencing it, but they certainly know what the consequences are. I tell this story often, but I was talking to someone, this was in a social setting a couple of years ago, and he was telling me that he was going to stop taking his diabetes medication. And I didn't ask him why, but I did say, what would make you start taking them again? And his response to me was, when my kidneys start failing. And he found that doing it was just too much trouble. He knew the consequences of not doing it, of not taking care of himself, not adhering to his medication. But it was just too much trouble for him. And one of the reasons why patients really have issues with the behaviors related to diabetes management and the motivation there is because they feel very overwhelmed. When they're first diagnosed or throughout their diabetes lifespan, they're always told you have to do this, you have to do this, and those behaviors keep piling up, and sometimes to a point where it's paralysis, and they feel that there's no way that they can be successful in that process. And so I think the first thing to do is to really have that conversation with patients and help them to identify what are the biggest barriers to their diabetes management behaviors. Is it that they're overwhelmed? Is it that they feel that no matter what they do, they can't succeed? Or is it that they can't afford the medication, or that they can't, they don't have time to exercise? It can be a variety of things. But I think it's really important before you intervene, you have to be able to identify what are the big things that are affecting patients' ability to take care of themselves. And then identify the behaviors that have the biggest impact. Because you can be given a list of 10 things that you need to do, but that's overwhelming. So what are the one or two most important things that you can do to change your behavior here? And then work with patients to set goals that are specific and measurable. So, for example, you don't want to say, I want you to lose weight, or I want to help you lose weight. But you want those goals to be really specific. I want to help you lose 5 pounds within the next 3 months. At that point, we can know whether we've been successful or not in that process. But by identifying specific behaviors and helping patients to break those down into small pieces and then see if they succeed in that process, it helps us in a couple of ways. First of all, it helps patients set goals. But also, if they're successful, and if you do this right, they will be successful, it helps them to gain a sense of self-efficacy. They know that they can do it, and what their behavior does make a difference. And that self-efficacy can really lead to more behavior change. Feeling like the things that you do really matter and really make a difference is a really critical part of this process and can be really helpful. Expectations. Many people with diabetes think that they see things as being very black or white. They believe that if they have to manage their diabetes perfectly, and if they don't, then they fail. And we all know that it's not possible to manage diabetes perfectly. Even if you follow all the rules, blood glucose levels are going to be variable, and people will not always follow their treatment regimen. But I think it's important to normalize this. To normalize it's impossible for everyone to be perfect all the time, and to help patients to understand that even with good diabetes management, even if those rules are followed, that it's not going to be predictable all the time. And really, based on that normalization and that understanding, help patients to set reasonable expectations for themselves around their diabetes behaviors and their glycemic control. Help them to know that not being perfect all the time is okay. And for many patients, that can be very freeing, because no one can be perfect. Trust me, I've tried. and it doesn't work. And it really leads to the sense of helplessness and a sense of hopelessness that can really send someone into a downward spiral of feeling burnt out. Feeling like, it's okay if I'm not all the time, that sometimes good enough is good enough, can be really freeing and really helpful for patients. And then finally, I want to talk about relationships. I think it's a really critical one. I think that, as we talked about before, especially with the patient Blake we talked about in the beginning, is that patients feel all alone. Oftentimes with diabetes, they feel very, very isolated. They feel like that what they're experiencing is theirs to deal with, and that no one else has ever experienced the same thing that they have. And so I think it's really important that people with diabetes are able to get the support they need. And that comes from all different areas. It comes from their healthcare team, really caring about the issues, not only about their glycemic control, but really about the struggle of living with diabetes and the emotional and psychosocial impact of that. That's really, really important. Having their friends and family members understand that and support them in that process. And also, I think really important, if at all possible, is to help people with diabetes connect with each other. I think that this serves a lot of really important, it helps people in a lot of ways. First of all, it helps people to see that they're not alone, that their experience is actually very normal compared to somebody else's experience who's living with diabetes, and that can be very comforting, in knowing that even though it's hard and that doesn't make it any easier, that the fact that someone else is walking my path with me, that can make someone feel really good about what they're doing to try. They can also share best practices. They can see that this person tried X, Y, or Z to help them overcome burnout, or to help them to exercise more, and they can share that together, and they can really support each other through that process. And so finding ways to connect others with diabetes is, I think, a really critical part of helping people to overcome burnout. There are a couple ways that you can do this. Obviously, in-person support groups is a great way. For the type 1 community, there are diabetes camps and there are diabetes groups that meet around the country. There's also a great online community via Twitter and Facebook, and there's a lot of blogs. A lot of those really focus on the type 1 population, but there are some for type 2s as well, which I would really encourage you to do some research on it and find and help and connect people so they can see the struggles that folks are facing. I think if you read the blogs and read the things that are online, the majority of it is around the emotional and behavioral challenges of living with diabetes, not about glycemic control. And so that shows me that there's a really missing piece there for patients. And it's important to connect them with that. Mary?
All righty, our last polling question. In a survey of people with type 2 diabetes, over 75% of respondents reported that they, A, are not sticking closely enough to a good meal plan, B, are not sticking to a good exercise plan, C, are not motivated to keep up with their diabetes self-management, and D, all of the above. So I'm going to go ahead and push the poll, give our attendees some time to answer, and in the meantime, I have a question for you, Dr. Heyman. If burnout does not equal laziness, how do I respond to patients that tell me they don't take care of their diabetes because they are lazy and don't want to monitor, eat right, take insulin meds, etc.?
That's a challenging one. So it may not. So I guess what I want to say is that diabetes burnout may not equal laziness, but that doesn't mean that people with diabetes are all not lazy. So I mean, it's possible that the person, maybe they are. I hate to say this, but maybe they are experiencing laziness. I don't want to call them lazy, but maybe they are experiencing laziness. And if that's the case, then maybe diabetes burnout is not the best way to characterize them. One suggestion there would be to continue to in an empathetic and friendly way to do some education, both psychoeducation about the challenges of living with diabetes and normalize those, and also give them some diabetes education about what their condition is and how their behavior is it could potentially hurt them. Because I think one of the biggest challenges that I have sometimes, and I'm sure that you do as well, is that we can't control people's behavior. We can give them the tools and resources that they need to help them to get better and to overcome some of these issues. But in the end, the responsibility for behavior change really lies on them. And that can be a really challenging thing as a healthcare provider.
Okay, great. I'm going to go ahead and close the poll, and I'm going to push the results and let you briefly address them before we move on.
So this is no surprise. So people with type 2 diabetes, especially, when they're diagnosed and throughout their treatment, they're given a list of things that they have to do, and it can be really, really hard to. And oftentimes they feel like that whatever they do is not good enough. That their motivation isn't good enough, that their diet and exercise is not good enough, and that can really be challenging and can lead to lots of a lack of self-efficacy in that sense. And so I wanted to share that data with you. Great. And so the key takeaways here are we want to help patients identify, overcome some of the barriers to treatment. We want to help patients that we want the patients to their management, help them to develop a support system. And then, of course, if patients are dealing with issues that are outside of your scope of competence or they need more intensive treatment, of course, refer them to appropriate behavioral health treatment if that's appropriate, which it can sometimes be a challenge to find appropriate folks who have diabetes knowledge around the country. But if you have that resource, I would encourage you to use it as much as possible. So I want to come back as we finish up this presentation and come back to the patients that we had talked about in the beginning. What happened to Frank? Frank was able to find a new physician who really listened to his concerns. One of his biggest concerns at the beginning was his doctor wasn't listening to him. And so he was able to find that physician. He also found that he had some control over his health. Even though he had some complications, he was still able to engage with his health, and he was able to do things that matter and that made a difference in his glycemic control and in his complications outcome. And he also really opened up to his family and friends about his struggles, and really was able to get the support that he needed from them, which was really lacking for him in the beginning. Cindy was able to learn to break down some of the big pieces of her diabetes management into more manageable pieces. And she was also, in that process, she gained some self-efficacy, but she also came to realize that she does not have to be perfect all the time. And just because she had fallen off the wagon, if you will, one day, didn't mean that she lost everything that she gained. Much like with weight loss, in general, by cheating one day doesn't mean you can't get back on and start over, keep on going the next day, not don't have to start over again. And she was also able to find a group of folks to support her, and they were able to celebrate their successes and support each other in their struggles. And then with Blake is still having some challenges. He really is he's struggling with managing his diabetes burnout. Some days are better than others. Some days he's able to manage diabetes effectively, and sometimes not. And this really continues to cause conflict both for him and his family. And one of the sticks that a carrot that's being used for Blake is that he wants an insulin pump. He feels that will make diabetes management much better. But his endocrinologist will not prescribe one until his management is more consistent, until he's checking his blood glucose levels at least 4 times a day and taking insulin as prescribed. And so that for him is really kind of the motivating factor. And some days some days are more motivated than others for him. So he's still experiencing challenges, and I think it's important to point this out. And I'm using him as an example because we're not always successful, and this is an ongoing process. It's not a one intervention, a one-time intervention, but it's an ongoing process with patients, and some of them need more support and more long-term support than others do. So this is a variation on a quote that I really would like to share with you that really kind of sums up the presentation. Diabetes is a full-time job that no one applies for, no one wants. If you get the job, you can't turn it down. There's no pay, no vacation time, and no matter how bad it gets, you just can't quit. I think that's an important perspective, again, to keep in mind as you're working with patients because, folks, motivation is hard, and it's especially hard when you're you have to be motivated to do something that you really don't want to do and never asked to do in the first place. So on that note, I know we have a couple minutes left, and I'm happy to answer any questions that you guys have.
Thank you, Dr. Heyman. I'll give you a question from one of our attendees. Would you say that it is easier to prevent burnout or to resolve it? Or, in other words, do you think that burnout can be 100% avoidable if approached correctly?
I'm not sure that it can be. I think the answer is that I think that it can be prevented. I think that by integrating some of these ideas into diabetes treatment from the beginning, from the time of diagnosis or soon thereafter, and giving people tools that they need by having that empathetic ear and really listening to your patient, by giving them resources that they need to change their behaviors, to set those expectations. I think that prevention is possible in some cases. However, because patients feel that support throughout. But in the end, living with diabetes is really hard. And people may experience things that they weren't expecting and that we weren't expecting as healthcare providers. And so while I think giving them those tools from the beginning can be really helpful and I think should be best practice, it can't always be avoided, and sometimes people will experience burnout. They will experience these emotional challenges. And we as healthcare providers need to be equipped with the tools to be able to help them to overcome them.
Okay, great. We'll have time for one more question kind of comment. And one of our attendees says, many older patients saw their parent or parents with diabetes go through amputations, and worse, due to medicines in those days were not as sophisticated as today. So many feel hopeless in that respect. Any comments?
Yeah, I think that's a very normal process. I think that the first thing I do is really to normalize their experience. What they saw, what they've dealt with their family members has been very traumatic. I think there's a couple things that we can do, or a couple things that's important to keep in mind. Is that one that our ways of managing diabetes now and the tools that we have are much more sophisticated, and so helping people to understand that and give them a sense of self-efficacy that their behavior can make a difference. Is really a really important thing. I think that often have people who have had that experience really feel that they feel a sense of hopelessness, or that they're resigned to having the same thing happen to them that happened to folks that they know who have gone before them, and they feel that no matter what they do, it's going to happen to them anyway. And so giving folks that sense of hope, I think, is really, really an important thing, and empathizing with them, but also it's empathy. That you're sorry that what happened to your parents and what they saw, but also give them a sense of hope that we have new tools and we have new both medicines but also behavioral tools that we can use to help patients along and give them the support that they need.
Great. Well, we're just about out of time, so I want to thank you, Dr. Heyman, for a wonderful presentation.